This lecture is for the undergraduate dental students. The title of the lecture is The Vertical Discrepancy, given by Dr.Nadia, a specialist and a lecturer orthodontist. The vertical relationship between the maxillary teeth and the mandibular teeth is usually represented by the amount of the overbite. Normally, the upper teeth should overlap the lower teeth. So the overbite can be defined as the vertical overlap between the tips of the maxillary and the mandibular teeth in occlusion. The normal range is that the maxillary teeth should cover the mandibular teeth about 2 to 4 mm. Or in other words, the upper teeth should cover the lower teeth about 1/3 to 1/2 of their clinical crown height. This is the normal values. Now for the classifications of the overbite, we have different types of the overbite of the vertical relationship between the upper and the lower teeth. The first one is the decreased overlap, which means that the maxillary incisors overlap the mandibular incisors less than 1/3 of the lower incisor clinical crown height. And if that lack of overlap were severe, that there is no vertical overlap between the upper and the lower teeth, it is called as an anterior open bite. And the measurement usually should be done as the amount of the incisor separation. The second one is the deep bite. From its name, if the maxillary incisors overlap the mandibular incisors vertically by greater than 1/2 of the lower incisor clinical crown height, we say it as a deep bite. And if the lower incisors touch the upper incisors or the palatal mucosa, we say it as complete overbite. But if we have a deep bite but the lower incisors do not touch the upper incisors or the palatal mucosa, we called it as incomplete overbite. Now in the cases when we have a complete overbite and there is a trauma in the lower labial mucosa, we called it a traumatic deep bite. And if the trauma was in the upper and the lower jaw, like the upper incisors are traumatizing the labial mucosa, the lower labial mucosa, and the lower incisors are traumatizing the upper palatal mucosa, we said it as bitraumatic deep bites. Now let's start by defining the open bite. As we said before, it is the lack of the vertical overlap between the maxillary and the mandibular teeth when the jaws are in centric occlusion. Generally, it is deteriorating the facial aspect. It impairs the mastication and the speech and subjecting the patient to uncomfortable situation. So it affects both the aesthetic appearance and the normal function of the patient. We have different classification systems. Some of them classifying the open bite according to the etiology as being dental open bite or skeletal open bite. Now the dental open bite can be further classified as anterior or posterior according to the location. The posterior can be also classified as unilateral or bilateral if it was affecting both sides of the jaw. In the same way, we can classify the skeletal open bite, which means that the main etiological cause are skeletal, including the maxilla or the mandible or both of them. And further, according to the location, it can be classified as anterior or posterior, and posteriorly as being unilateral or bilateral. For the etiology, we have different etiological factors for the development of the anterior open bite, including those important elements that are common with all other malocclusions, including the skeletal pattern, the soft tissue, the habits, and the localized failure of development, the environmental cause. I will start by explaining the skeletal pattern. In orthodontics, the patients are usually classified into 3 groups according to their growth pattern. We have the horizontal growth pattern, we have the normal, and we have the vertical growth pattern. So individuals with a tendency to vertical rather than horizontal facial growth usually will show an increased vertical skeletal proportions. So the patient will have an increase in the lower facial height, and there will be an increase in the interocclusal distance between the maxilla and the mandible. Normally, the labial segment appear to be able to compensate for this increase in the lower facial height and for this increase in the interocclusal distance, but to a limited extent. So when we have a marked discrepancy, a marked vertical discrepancy that exceed this ability, that exceed this incisor's compensatory ability, the result will be the presence of an anterior open bite. Abnormalities in the growth pattern of the maxilla or mandible or both of them will lead to the development of anterior open bite. For instance, if we have an upward rotation of the maxilla, or what is said counterclockwise rotation of maxilla, or if we have a downward rotation of the mandible or clockwise rotation of the mandible, or in some people or some patient we have both of them, which means that the maxilla is rotating upward and the mandible is rotating downward, or if we have a vertical maxillary axis. Any one of those abnormalities in the growth will lead to the development of anterior open bite. For the soft tissue factor, in general, the patients with increased vertical skeletal proportions have higher likelihood that they also have incompetency of the lips. As you know, that during function, during swallowing and during speech, we need to obtain the anterior oral seal. And this is normally obtained by the lip-to-lip contacts. And the tongue will be elevated to the roof of the mouth, lightly touching the palatal surface of the teeth. If the patients have lip incompetency, this anterior oral seal will be obtained by placing the tongue forward between the anterior teeth. So, this abnormality in the tongue function, this excessive activity of the tongue in the act of swallowing or even at rest will change the incisor axial inclination and will cause an open bite. But in this situation, we have to consider the activity of the tongue. If it was the primary cause of malocclusion due to the abnormality in the tongue activity, it is called endogenous or primary tongue thrust, which means, in other words, that the tongue is the main cause for developing the anterior open bite due to the abnormality in the muscle function of the tongue. And usually those cases, fortunately, are rare. They have a family history, they have lisping during the speech, and during the treatment we should be careful because the relapse is high in those situations. But fortunately, as we said, that the majority of the cases, this abnormality of the tongue function is adaptive, which means that the patient already has an anterior open bite, but during function, the tongue is protruding forward to obtain the anterior oral seal, so it has a secondary role. This secondary role will maintain the already existing anterior open bite or it will worsen it, but it is not the primary cause. So if we treat the anterior open bite, the tongue will return to its normal position and will function normally. The development of the vertical dimension is also affected by the presence of equilibrium between the tongue, between the lips, and between the cheeks, and the opposing dentition. So, if there is any parafunctional habits like thumb sucking, like anterior tongue thrusting, like mouth breathing, it will change this equilibrium. The patient is placing his thumb between the teeth. It will change the axial inclination of the upper anterior teeth. It will cause flaring of the upper anterior teeth, flaring of the upper incisors. Besides, it will separate the maxilla and the mandible and lowering the tongue. This will cause constriction of the maxilla and over-eruption of the posterior teeth, and the result is the presence of an anterior open bite. If it was associated with thumb sucking, normally seen that this open bite is asymmetrical. It will follow the position of the thumb. Unless the patient is sucking two fingers, so the anterior open bite will be symmetrical. The same goes for mouth breathing. Opening the mouth and lowering the lower jaw and lowering the tongue in a downward position so that it will not fold the palate to exert its force and stimulate the growth of the palate will result in constriction of the maxilla, over eruption of the posterior teeth, and there will be an anterior open bite. Now for the clinical features of the dental anterior open bite, because as you remember at the beginning of the lecture we said it is classified as being dental or skeletal. For the dental, predominantly the dental-alveolar open bite will be less severe than the skeletal and restricted to the anterior teeth. So the open bite will be confined to the anterior segment, extending from the canine or the first premolar to the canine or the first premolar of the other sides. Besides, the maxillary and the mandibular anterior teeth will be proclined. Spacing may be also seen. We will have a narrowing of the maxillary arch and a fish mouth appearance, as we can see. While the clinical feature of the skeletal anterior open bite is a little bit different. As we said, it will be more severe, extending, including all the teeth, and only the posterior molars will be in contact with each other, as we can see from this picture. Also, we will have a mild crowding with uprighted incisors. We will have excessive gingival display with gingival hypertrophy, especially if it was associated with vertical maxillary excess. The maxillary occlusal plane will be tilted upward, the mandibular occlusal plane or canted downward, and we will have a narrowing of the maxillary arch. The extraoral feature of the skeletal open bite will be as follows. First of all, the patient will have a long face due to the increase in the lower anterior facial height and the decrease in the posterior facial height. Also, the patient will have incompetent lips. The lower lip will be everted. We will have increase in the gonial angle due to the downward rotation of the mandible. The maxillary plane will be increased. The mandibular plane is increased due to the rotation. The maxillary plane is rotated upward. As we said before, the mandibular plane is rotated downward. Also, we will have a decrease in the nasolabial angle and a shallow mentolabial sulcus. Upon the cephalometric examination, we can see that we will have a clockwise rotation of the mandible, a counterclockwise or anticlockwise rotation of the maxilla, vertical maxillary axis, and a steep anterior cranial base. The posterior open bite is usually characterized by the lack of contact between the posterior or when the teeth are in centric occlusion. It can be unilateral or bilateral. The main etiology that causes the posterior open bite are the presence of lateral tongue thrusting, which means that the patient is placing his tongue between the upper and the lower posterior teeth so to prevent the normal eruption of those teeth. The other cause is the ankylosis, or the submerged posterior teeth that fail to reach the occlusal plane, and it will cause the posterior open bite, as we can see from those pictures. The management of the cases with open bite is greatly dependent on the main cause that lead to the development of the open bite. If the patient has an open bite that is associated with abnormal habit, our first step will be to convince the patient to stop the habit. If the patient was in the primary dentition, we should start encouraging him or her by gifts, by presents, by illustrations and explanations. But as the patient enters into the mixed dentition period, the patient should be convinced to stop the habit and we should start using the habit-breaking appliances. Those habit-breaking appliances, they are either fixed or removable. As we can see here, it consists basically from a tongue grip or a tongue spikes that is cemented on bands on the molar teeth. Or we can use the removable habit-breaking appliances, especially in cooperative patients. Those removable habit-breaking appliances basically consist of the tongue grip or the tongue spikes extending anteriorly. The tongue will be locked posterior to it and it will prevent the tongue from protruded anteriorly. Also, it will prevent the child from entering his thumb inside the patient mouth. Also, it consists of an Adam clasp Hawley arch. If the anterior open bite was associated with a constriction of the maxilla with posterior cross bite, we should consider using an expansion screw in the removable appliance to expand the maxilla while breaking the habit of the patient. Now, if we have a growing patient with a skeletal open bite, we should consider using one of the growth-modifying appliances, like the myofunctional appliances or the orthopedic appliances. Our main goal here is to vertical control or intrude the buccal segments. So we are going to reduce the posterior dental heights, and this will result in auto-forward rotation of the mandible and closing down the anterior open bite. This is because the molars are located closer to the condylar hinge, so even a small amount of intrusion will result in a greater closure anteriorly. In children, we can use the hypal headgear either directly cemented to a band on the sixes or attached to a removable appliances. So this hypal headgear will control the posterior vertical growth of the maxilla, and this will redirect the mandibular growth in a more anterior than vertical direction. This headgear can be used alone or in conjunction with myofunctional appliances like the modified activator with posterior white blocks or the Frankel 4, especially in cases of class 2 malocclusion with anterior open bites. But the patient should wear these appliances to be effective about 12 to 14 hours per day, and we should continue using these appliances until the cessation of growth after adolescence, because the vertical growth pattern will continue during the adolescence. Or, and sometimes we can use the high pull, the vertical pull chin cup. And this can be used in the correction of anterior open bite in the pre-adolescent age group to redirect the growth of the mandible in a more anterior direction. So, if we have a patient who has a mild skeletal or mild to moderate dental open bite and he is not growing, we can treat it by using the fixed orthodontic appliances. And here we have two options, either to extrude the anteriors or to intrude the posteriors. If we consider extruding the anteriors, we can use the box elastic for the anterior teeth, including the anterior teeth, and this will cause extrusion of those teeth. And if we have a posterior open bite, we can also use a box elastic to extrude them. But ideally, those patients are best treated by intrusion of the posterior teeth by using either mini plates or screws palatally or sometimes palatally and buccally to reduce the buccal tipping of the posterior teeth. We have to keep in mind that the treatment of the open bite is not easy and it is more difficult than the deep bite. There are many considerations that we have to think about it before treating those cases. For instance, if we want to extrude the anteriors, we have to carefully examine the amount of the incisor display, the amount of the gingival display, and the smile arc of the patient, both at smile and at rest, because we may end up with a gummy smile. So all these factors should be considered when treating patients with fixed orthodontic appliance and when deciding how we are going to treat the patient by extrusion of the anteriors or intruding the posteriors. If the patient has a severe skeletal open bite and he is not growing, the best is to wait for him to complete his growth and should be referred for a maxillofacial surgeon to start the orthodontic surgery. And in those cases, if the patient has a maxillary excess, we may consider using maxillary impaction, or if he have a clockwise rotation of the maxilla or mandible, it should be corrected surgically to have a stable results. The another vertical discrepancy that we are going to explain is the deep bite, which is just the opposite of the open bite. So by definition, it is a condition of excessive overbite where the vertical measurement between the maxillary and the mandibular incisal margin is excessive, is more than 4 mm, and this is measured when the mandible is in the centric or habitual occlusion. The deep bite may be complete if there is a contact between the incisors or between the incisor and the opposing mucosa, or incomplete if we don't have any contact between the incisors or between the incisors and the mucosa. It could be skeletal, dental, it could be traumatic if we have a trauma to the palatal mucosa, or bitraumatic if we have a trauma to the palatal mucosa and to the labial mucosa. The dental deep bite, from its name, it is confined to the dentition, where there is extrusion of the anteriors and intrusion of the molars. We have a deep curve of sp, so they will have an elongation of the lower anteriors. Or sometimes it is often seen in class 2 cases, where there is a lack of the occlusal stop to the lower anterior, so there will be an over-eruption of those anteriors. Deep bite are usually more difficult to be treated and are usually of genetic origin. Most commonly are caused by an upward and forward rotation of the mandible, the counterclockwise rotation of the mandible, or by the clockwise rotation of the maxilla, or sometimes both of them. But the skeletal deep bite are usually most commonly seen in the cases of Angel's class 2 division 2 malocclusion. Regarding the clinical features of the deep bite, extraorally the patient will have a decrease in the lower facial height. In the normal situation, the patient face can be divided into 3/3. Those 3/3 should be approximately equal to each other. The first one is extended from the hairline to the glabella. The second or the middle facial third extend from the glabella to the base of the nose, and the lower facial third extend from the base of the nose to the base of the chin. Within the lower facial third, we should have also 3/3. The upper lip occupy the upper 1/3 and the lower lip occupy the lower 2/3. So in the patient with a deep bite, with a skeletal deep bite, we expect him to have a decrease in the lower facial height. Besides, we will have a decrease in the mandibular plane angle. We will have also a decrease in the gonial angle due to the upward or counterclockwise rotation of the mandible. Cephalometrically, we can differentiate between the dental deep bite and the skeletal deep bite. If the patient has a dental deep bite, we can see that he has got also an increase in the interincisal angle due to the retroclination of the upper anteriors. But if the patient has a skeletal deep bite, we may notice that he will have an increase in the ramus height and also a decrease in the Frankfurt mandibular plane angle with an upward and forward rotation of the mandible. Intraorally, we will see that the patient have an increased overbite more than the 4 mm, a decrease in the overjet due to the retroclination of the upper anteriors, extrusion of the maxillary anteriors, intrusion of the maxillary posteriors, and gingivitis in the lower anterior region, especially if the deep bite is complete and traumatic. Treatment of the deep bite can be done by using the removable orthodontic appliances, the myofunctional appliances, or the fixed orthodontic appliances. And the decision will greatly depend on the patient age, on the severity of the case, and whether we want to intrude the anteriors or extrude the posteriors to correct the deep bite. Regarding the removable orthodontic appliances that are commonly used to correct the deep bite, those appliances are incorporating an anterior bite planes. Those anterior bite planes will disocclude the posterior teeth and encourage their super-eruption, but the patient has to be growing. Now the decision whether to use a flat anterior bite plane or an inclined anterior bite plane is greatly dependent on the case. If the patient has only an increase in the overbite, but the overjet is normal, we should consider using the flat anterior bite plane to encourage the over-eruption of the posterior teeth and to level the excessive curve of sp. But if the patient have an increase in the overjet and an increase in the overbite, like in the cases of a mild class 2 with increased overbite, we should use an inclined anterior bite plane. This inclined anterior bite plane will encourage the forward positioning of the mandible and will cause a labial tipping of the lower anteriors. The reciprocal force will cause a slight retroclination of the upper anteriors. At the same time, the anterior bite plane will separate the posterior teeth, and this will cause an over-eruption of those teeth. So at the same time, we are going to correct the overjet and the overbite. In this video, we can see that this patient has a deep bite. and he is going to be treated by using a removable appliance with an anterior bite plate. The anterior bite plate is a thickening of acrylic located anteriorly, about 2 to 3 mm in thickness. When the lower anterior teeth will occlude with this acrylic thickening, the posterior teeth will be disoccluded. There will be a space between them, so there will be an over-eruption or extrusion of those posterior teeth, and we will get a relative intrusion of the anterior teeth, and this will correct the deep bite. The myofunctional appliances can also be used to correct the deep bite, especially in mild to moderate cases and the patient is growing. And this is by using the activator, the bionator, or the Frankel appliances. In all of these myofunctional appliances, we are going to selectively grind the acrylic or trimming the acrylic selectively to encourage the extrusion of the posterior teeth, as we are going to see in the next. So this patient has a class 2 malocclusion with a deep bite. We are going to correct it by using a bionator with an anterior bite plane. The acrylic is also going to be trimmed posteriorly to allow the extrusion of the posterior teeth. So eventually the patient will correct, we are going to correct the overjet and the overbite of the patient. Regarding the retention, if the deep bite were corrected by intruding the maxillary interiors, we should instruct the patient to wear a removable retainer with an anterior bite plate to help to retain the results. The patient will be instructed to wear such retainer continuously for a period of about 4 to 6 months, and the overcorrection is usually desirable to prevent the relapse. This is the end of the lecture. If you have any question, please do not hesitate to contact me through the YouTube channel or through the Google Classroom. Thank you.